our group. Currently, just to show you that we operate in a structure, we have a board of directors chaired by Eric Bateman, a dissemination committee by Dr. Boulay from Montreal, and a science committee chaired by Dr. Fitzgerald from Vancouver, Canada. Now, those are just 3 names, but behind all of those names are many, many people who have contributed over the years in all of these committees, and we are very grateful to their work. But the key to our success as we see it today is what we call the GINA Assembly. These are people, a network of people who are volunteers. They don't charge us anything, we don't charge them anything. They agree to participate as being the sort of asthma ambassadors in their own country. They identify themselves, they contact us, say they want to do the work, and we sign them up. We're very eager to have as many people as possible in the GINA Assembly. We invite them to come to meet with us at the time of the ATS and ERS. We don't pay any travel, so these are people who already come to these ATS and ERS meetings. It's a wonderful way of developing a network, and these are the countries that now participate. There's well over 70 countries, I believe, listed there. Many of them are extremely active in developing their own asthma education programs. Many of them have taken our report and have made it more locally adapted, which is, we certainly suggest that this is something that can be done. The report has been revised 2 times. As I told you, it came out in 1995. It was revised in the year 2001 and again in the year 2006. But in each case, we had the chapters that are listed here. It's a fairly lengthy document, 100 pages, and it has a lot of information about the definition, diagnosis, different asthma medications, which are, of course, updated. Now, one of the strengths of our program is we do an annual update. So each year, after 2006, every single year, we have a panel of the scientific experts who go through this report, look at the published literature, and update it annually. In December, if you visit our website, you'll see our updated 2011 report. But ever since the beginning of this document, based in many ways on the very first NAEPP report, that it has been clear that it is reasonable to expect that in most patients with asthma, control of the disease can and should be achieved and maintained. So we started using that word asthma control right from the very beginning. And it's changed its context over the years, as you know, but that's still the major #1 goal of the program. And of course, this is important because we believe that if you control asthma, as you all know, that you have a better quality of life. And what's important in our global program is you can begin to show that there is a reduction in economic costs if you control asthma. This is what GINA describes as asthma control. No daytime symptoms, no limitations of activity, no nocturnal symptoms, no need for the reliever medication, and normal lung function. We have the graph that shows the characteristics on the left-hand side. We define controlled, partly controlled, and uncontrolled asthma. We encourage people to recognize that assessing control is the first part of the algorithm. You also need to look at the patients to assess the future risks. Because, of course, any exacerbation should prompt review of maintenance treatment. So what I'm showing you, I hope, is that we try to make the messages as clear and concise as possible. These are messages that we want to convey to the healthcare communities, not to necessarily research scientists who are doing new clinical research, but people who are caring for patients out on the district levels. We have developed what we call a 5-component program. These are the 5 steps for taking care of your asthma patients, and they're all well articulated in this document. We believe that most patients can achieve good control of their asthma with optimal care through an active partnership with their healthcare professionals. Now, this active partnership with healthcare professionals means a lot when we're dealing with organizations where there are no physicians, and we work very closely with the nurse and other healthcare professionals. We say that working together with the patients, it's important to assess control, treat to achieve control, and monitor to maintain control. Those are the 3 key steps. And then we have an algorithm, which you have seen our controlled, partly controlled, uncontrolled, and exacerbation. We have the treatment actions to take at each step. We recommend reduction of medications if asthma is controlled, and increasing medications if the asthma is uncontrolled. GINA has 5 treatment steps, which are well articulated in this nice little cartoon. We believe for each step, it's important that the patients have an active asthma education program, that environmental control and risk factors are well identified, and that as needed, rapid-acting beta agonists for each of the steps. But depending on the level of control, if your patient is uncontrolled, GINA recommends starting at step 3 and reducing medications if asthma is controlled, and increasing medications if asthma is uncontrolled. Again, relatively simple messages for healthcare providers. When control has been achieved, it's essential to maintain control, establish the lowest step and dose required, and it should be monitored at all times by both the healthcare professional and by the patient. In addition to our main report that I've been discussing, we have another report that just came out in the year 2009 and again is updated annually. It's about dealing with children 5 years and younger. This was a cohort of patients that we always felt was well covered within our main document, but the pediatricians urged us to come out with another report that focused on the under 5 category, and we have done so. This report is in a full report and a pocket guide like all of our other documents. They're all available on our website. They've all can be downloaded and have been translated into many different languages. So I just would like to turn again back to the members of the GINA Assembly, because it's really, these are the ambassadors that do the work. We can make the documents, we can prepare the information that's credible and well scientifically endorsed, but how to actually get it disseminated and implemented takes people on the ground. And these are our foot soldiers, so to speak. Every year, GINA has a World Asthma Day. This year it was on May 3rd. It's always the 3rd Tuesday in the month of May. And these ambassadors are out there developing programs to have information available for the public to help them meet our main goal, raise awareness of the burden of asthma. And it's incredible what they have done. This is just one of hundreds of thousands of cartoons and pictures I could have picked, but I thought this was an interesting display to show that in China in 2005, one of the main persons who participated on our first GINA program with the World Health Organization is in China, Dr. Chen. She always has a group of conferences, she always has groups of patients, and she always develops documents that she can hand out to the people who come to her conferences. We were in Vietnam in 2008 for World Asthma Day. You can see on the top cartoon there was a wonderful presentation of all of these people had asthma. And they gave a 1-hour concert to us that was absolutely beautiful. And then that was followed by a motorbike parade. If you've ever been in Hanoi, you'll know that there's millions and millions and millions of motorbikes. In this group, there must have been 200 of them with their motorbikes. They all had World Asthma Day t-shirts, World Asthma Day flags, and they actually were down the main street of Hanoi with a police escort to show about World Asthma Day. So it doesn't take a lot to get people going and realizing that these are things to raise awareness that asthma is an important disease. Well, I just would like to bring back into the picture the World Health Organization. Again, we can do a lot of developing documents. We could have World Asthma Day, but unless the people who are in the government are endorsing the principles of asthma care, chronic disease care, there's not much the people on the ground can do. You really need to have the leadership of the country. So we were very pleased in the year 2006 that the World Health Organization decided to launch a program called the Global Alliance Against Chronic Respiratory Diseases. And this was to, again, bring the attention of the importance of these diseases to the Ministry of Health people in countries around the world. Many, many organizations joined this effort. GINA was one of the, is, and to this day, one of the main contributors to the GARD program. You'll see many organizations around the theme here. Some of them are more active than others, but the most important thing is everybody has endorsed the concept of the need for a global chronic respiratory disease effort. Well, so with all this work, has there been an impact? Well, I'd like to, of course, believe that there has been an impact, and I just would like to show you some data. The beginning of the most important probably is the work from Finland. This is a program that has been done throughout the entire country of Finland. And they've actually shown that you can implement a national asthma program that can make a big impact on patient care. This is just one of the many slides that could have been chosen from Dr. Lahtela's thorax paper in the year 2006, but it really summarizes the important information. As they began their program, it became very clear that there were many asthmatics that were not diagnosed. And you can see the increase in the numbers of patients. But yet, in spite of that, they have kept the drug costs per patient relatively constant. But what's absolutely essential to see is the reduction in hospitalizations and in mortality. People do not need to go to the hospital. They do not need to die from asthma if there is a effective national asthma education program. Dr. Lahtela and the group, many of these people participate on our GINA program. They have expanded their program. Now the people from Poland and the people from Brazil have shown that they too can just take a national program, they can implement it. These are all following the GINA guidelines, GINA principles. Here too, in just a 3-year period in Poland, you can see that they've identified more patients, but they've also shown, even in a 3-year period, a relatively important decrease in hospitalizations. So these programs can work. They can make a difference. And they can show that implementing the best standards of care in everyday practice, if you take into account the local conditions of a given country, you include the health care and the drug reimbursement system, you can control asthma in virtually all patients with modern medications, and hospitalizations can be reduced. These are important messages to convey to those people up there in the ministry who are going to be making the recommendations for should medications become available.